Alrighty. Good morning, everyone. Welcome to Ocular Pathology Rounds, Wednesday, May 17th, 2023. I am Gillian Shaw, and I will begin with the first case. So this is the right eye from a 10-year-old Cocker Spaniel. The history we got was that the eye was blind. There was conjunctival hyperemia, normal cornea, trace to mild aqueous flare, dilated pupil, few dorsal, peripheral, punctate, anterior cortical / subcapsular cataracts, and large white mass extending from the optic nerve into the anterior vitreous with multifocal overlying dot / blot retinal hemorrhages, and limited view of apparent low retinal detachment. So we received the globe, and this is what we found. They also specifically said, no, actually, they didn't explain that at all. But anyway, so when I hemisected the globe, here is the white mass that they were referring to clinically. Here's the an area of retinal detachment. There is a little bit of hemorrhage in the vitreous. The anterior segment looks relatively normal. And then the mass is in the eye and also outside of the eye. So here's the optic nerve right here, and here's that mass attached to the optic nerve. So in this low mag view, you can see here's the mass, and then here's the optic nerve, and then there's more of the mass right outside of the eye. They actually submitted two pieces of tissue. One was the globe with the attached mass, and one was an extra piece of tissue that I could tell had part of the optic nerve in it. And let's see if this will work. Might not. Yeah. I couldn't tell which end of this tissue was the surgical margin and which one wasn't. But so when you sort of overlap them here, here's the optic nerve here that's attached to the eye, and here it continues here. And then here's more of the same mass that's continuous with this piece. So luckily we were able to tell, or I was able to tell histologically after the fact. But we'll get back to that in a sec. So let's go ahead and look higher mag at this globe. So as he pointed out, the anterior segment was relatively normal. There was preirital fibrovascular membrane right here, causing both peripheral anterior synechia as well as ectropion uvea. So you can see how the wow, the mouse is really not responding very well. You can see how that pupillary margin of the iris kind of curls around on itself there. And there's also a preirital fibrovascular membrane present on the other iris leaflet as well, causing peripheral anterior synechia. He said there was actually no glaucoma, so the IOP was normal. But anyway, so as we move back, here's that mass that we saw subgrossly in the gross photo and also in the low mag view. And it is composed of spindle to polygonal cells that are arranged mostly in sheets, with maybe some vague bundles and streams. You can see there are a few little blood vessels throughout. Some of them are larger in other areas. They have relatively indistinct cell borders, some vacuolated cytoplasm, some round to oval nuclei with fairly prominent single nucleoli, like this guy, and wow, this guy. And then you can also see that there are some mitotic figures around. There's a really funny one right there. Okay, I just passed it right here. Some atypical mitotic figures as well. There are some areas of necrosis in this mass, which is usually an indication of fairly fast growth. Here's some areas of hemorrhage, which is maybe what he was seeing in the fundus as well. So when we move outside the eye, we have relatively similar looking neoplasm. Where the cells are looking relatively similar. When we go a little bit further, the neoplasm becomes a lot less dense. And the cells are sort of embedded and separated by this sort of maybe mildly basophilic fibrillar matrix, which I thought was interesting. And it's very much in contrast to what the cells were embedded in, both in the globe and the part that was outside of the globe, but closer to the sclera. So I thought that was interesting. So this is another example of a retinal / optic nerve head glioma. Leandro presented one 2 weeks ago as well. And I know that this is a very recent repeat, but I thought this one was really interesting because of this area of interesting matrix. So let's actually, before I talk about what else I did, let's look at that extra piece of tissue that they gave us. Because, so here is more of the mass, and then here is more of the optic nerve. So the optic nerve is looking very abnormal. It's hypercellular. There are areas of hemorrhage right up in here, right in this area. And then some of these cells, so whenever you have optic nerve damage, they could be glial cells that are reacting to damage to the optic nerve. But in this case, I'm very suspicious that they are neoplastic cells. It is a little bit hard to tell the difference, especially because the type of tumor we're identifying is a glioma also, so composed of glial cells of sorts. But with this type of tumor, the main prognostic feature in the eye is whether or not the optic nerve margin is clear of the neoplastic cells. So unfortunately, that area, the hypercellular nature of the optic nerve really does extend right up to the cut margin of the optic nerve here. So this is unfortunately a bad prognostic feature because the neoplastic cells can extend right up the optic nerve and affect the central nervous system or the brain. So this is the only prognostic feature that means anything, as far as we know, with retinal and optic nerve head gliomas, is whether or not the cells are present at the optic nerve margin, excuse me. So back to that interesting matrix that was present. I did an Alcian blue stain because the matrix to me looked very chondromatous or cartilage-like. And so I did an Alcian blue. An Alcian blue stain will typically stain cartilage bright blue, just like this. So as Leandro likes to call it, here's your chromotherapy for the day. So we have this matrix really stained beautifully with this Alcian blue stain, which indicates that there are some sort of polysaccharides here, and I'm trying to remember which ones. Mucopolysaccharides, I think, yeah. So this is an unusual feature, at least as far as the retinal gliomas go, or the intraocular gliomas that we see. So I thought that was kind of cool. I don't know how frequently this happens in gliomas of the CNS. But anyway, I thought that was kind of interesting. So those are all the features of this case. Unfortunately for this patient, we assume that the prognosis is not great because of that dirty optic nerve margin. And also, I felt that the neoplastic cells also extended to the margin of the sort of the part of the mass that was outside of the eye. So there we go. In the central nervous system, I'll kind of review what Leandro said last time. In the central nervous system, gliomas are divided into all different subtypes based on their morphologic features, as well as probably immunohistochemical markers at this point, in both humans and domestic species. But in the eye, we tend to not really try to distinguish the different types, mostly because, as far as we know, the only prognostic feature that matters at all is that optic nerve margin. So we don't bother trying to waste time and energy and efforts and money trying to differentiate the different types.
Yeah, if you go by the book, I would say the vast majority of our cases will uh, be classified as mixed gliomas because they have that astrocytic, sometimes more round appearance to it. We have very few cases that we were confident enough to call a specific lineage like an oligodendroglioma. I have 2 or 3 cases where they were very well differentiated in that way, but the majority of them, they don't differentiate well. And if you use all the features that they describe to grade, all of our cases will be, almost all of our cases will be classified as a high grade. But as Gideon just pointed out, the prognosis is very different because they're usually intraocular, so the main feature will be the extension in the optic nerve.
And also as a PSA for all the clinicians out there listening, so this extra piece of tissue was submitted with no sort of identification as to which end was which. In this case, it was easy to tell the difference between what was the actual surgical margin of the optic nerve and what wasn't. However, it's not always that obvious. And so when you take an extra piece of optic nerve in particular, when it's no longer attached to the globe, it's really awesome if you could throw a suture in one end and explain which end is which, or throw some biopsy ink on it or something, because sometimes we can't tell which end is which. And so that might make determining margins for something like this difficult. So there you go. All right, moving on. Next case is a left eye from a 16-and-a-half-year-old miniature dachshund. So the history we got, and also I'll tell you that we received this dog's other eye about 2 or 3 weeks before we received this one. And we diagnosed asymmetric uveitis. And so asymmetric uveitis, as a quick review, is a severe lens-induced uveitis, so associated with a cataract, that we predict or we assume means that the second eye of this patient is in danger of developing severe, similar ocular disease associated with a cataract. So unfortunately, in this case, our prediction was correct. And this dog's second eye went bad really fast after the first one and was enucleated and sent to us. So here is the second eye. But when I show you the slides, I'll show you the slide of the first eye. But what we see grossly here is that there's this sort of cloudy material in all of the ocular chambers. So it's in the vitreal space, it's up in the posterior chamber and in the anterior chamber. And that is consistent with a high protein exudate that's in the intraocular chambers, which in turn is consistent with intraocular inflammation and leakage of serum out of blood vessels. And so what we also have is a cataract. It's not a very significant or impressive cataract, but you can see the cortex is opaque. And then also what you can see, oh, this might help. What you can also see is that there's this white material lining the iris surface, both the anterior surface and the posterior iris surface. So that is characteristic of this disease, and that's composed of inflammatory cells. And so that's about all we can see in this gross photo. Sorry about that. Okay. So let's go ahead and look at our slides. Here is actually the slide of the first eye that was enucleated. And so I'll show it really briefly and then show you that what we have in the second enucleated eye is very similar. So here's the first eye that was enucleated about 2 or 3 weeks prior to the other one. What we have is some significant peripheral corneal stromal vascularization. Here's some proteinaceous material in the anterior chamber, and then the iris itself is pretty much effaced by inflammation. It's evident over here as well. And that inflammation is also on the iris surface that we can tell in this low mag view. There's also a significant pan-uveal stromal infiltrate, so this choroid is expanded by inflammation. And that's about what we're going to see at the sub-gross view. So let me just quickly show you what that inflammation looks like. So we have inflammation that is both within the iris stroma, composed mostly of lymphocytes and plasma cells with some macrophages thrown in. And then also On the surface, we have some epithelioid macrophages that are sort of mingling with a fibrovascular membrane. Just like how it's not the same. Anyway, so here's a blood vessel within that fibrovascular membrane. Some of these macrophages do contain melanin, and this is presumed to be the result of destruction of uveal stromal melanocytes associated with all this inflammation. When we look at the lens to try to confirm that there is a cataract in this previously enucleated eye, there is cortical lens fiber liquefaction with a few more ganglion globules being formed there. And one of the hallmark features that we look for when we want to diagnose asymmetric uveitis is leakage of liquefied lens protein through an intact lens capsule. And I think it was actually pretty hard to find in this one. So I don't have any good examples in this eye, but we were most suspicious of asymmetric uveitis in this elderly dachshund. So we got the second eye 2 to 3 weeks later, and we'll just jump right to the low mag view. So this is, unfortunately, as I said, our prediction was correct. So what we have here is a severely inflamed iris with a really thick layer of epithelioid macrophages on the surface. Right here, all these guys are macrophages. We have a few more that also contain melanin in this eye. And then the uveal stromal infiltrate itself is mostly plasma cells and fewer lymphocytes with a few other macrophages thrown in there. So let's check out our cataract. So we have, once again, cortical lens fiber degeneration and liquefaction present there. The back is of the lens is not very well sampled. I'm looking once again for that liquefied lens protein. We've got a lot of fibrin mixed in here, which is all of the more fibrillar material. But some of these eosinophilic globs are probably that the leakage of liquefied lens protein. So other features that we look for to diagnose asymmetric uveitis include retinal necrosis, which I don't think was present in this eye, but I think it was present in the other one. Actually, yeah, it's present here. So often, well, it begins in the earlier stages with peripheral retinal necrosis, but it can progress to the entire retina being affected. So here we have identifiable retina, and then it just peters out into this necrotic neuropill material. We also have a pan-uveitis, so you can see all of the inflammatory cells in the choroid as well. And sometimes, or I should actually say frequently, it will actually extend right into the limbal sclera and lead to scleral ruptures, which were not present in this eye, but actually were present in the previous eye. So as I said, unfortunately, our prediction was correct, and this dog's second eye went bad relatively quickly after the first one. They don't always go bad quite as quickly. Sometimes it's a little bit longer. And sometimes I think clinicians will try to treat with various anti-inflammatories, which might help to keep the eye in the dog's head and comfortable for longer than what happened here. So there we go.
Is there any history of diabetes in this guy?
No, actually, heart murmur, but that's it. So, all right, now it's somebody else's turn.
I've got kind of a pair of cases today, starting with this dog. So this is a 10-year-old neutered male cattle dog mix. They present with a couple of kind of non-specific things. Clinically, mostly it sounds like they probably were having trouble seeing past the lens for a good reason. There was buthalmia, there was some corneal vascularization and cloudiness, a shallow anterior chamber. They described 360-degree posterior smechia and a cataract. And you can see a lot of those features on the hemisected view of the globe post-fixation too. You've got your cloudy cornea up here. There's barely an anterior chamber. Both lens and iris is sort of anteriorly positioned. You can see the posterior synechia, or at least guess that it's probably there prehisto with the iris leaflets tamped down to the front of the lens here. And the focal, they actually describe a focal cataract clinically, and you can kind of see that here. The opacity in the lens that you can see grossly is sort of off center like this. And there's this big billow of sort of tan white exudate in the mostly posterior chamber, a little bit in the vitreous, interestingly kind of centered around that area of the lens. There's also retinal detachment. And so very interesting initial view. And then we'll take a look histologically. Let's see what the subgross looks like initially. So just kind of wanted to show you the histo view. Maybe we can back out a little. This is never that good. All right. So there's all this purple here, which usually means there's too many cells. So all that exudate we saw grossly, kind of around the area of the sort of equatorial lens. And we'll just switch slide to the, yeah. Subgross is often not that great. Let's see. So we've rotated 90 degrees clockwise. And one of the first things that you see with this globe is a couple of sites of lens capsule rupture. Here we're in the anterior lens capsule. We've got the site of rupture. We've got posterior synechia with the iris fused over top of that. And then you can see the inflammatory cells dissecting into the lens itself underneath that. And then we also have a site of rupture over here at the equatorial lens where a lot of that exudate was. So here's one end, here's the other, and you actually have little fragments of lens fibers. And if I go closer, little globules of degenerate lens protein, these guys here, just sort of exploding into the posterior chamber from this site of rupture. And then same thing here, neutrophils spreading into the remaining lens. Now, when you see this phakitis like this, if you walk yourself into the lens along these areas where there are inflammatory cells, and especially if you kind of track into these cracks in the lens fibers where the lens is sort of liquefied and degenerate, you may often see something of interest. So just a little tip there. So if I head into these cracks here, for example, maybe, or maybe it won't look great on the camera. Oh, it's always one of those things where I find it just fine in like 2 seconds when I'm not in the hot seat, and then when I am in the hot seat, I can't. Even when I practice initially. There we go. So if you walk yourself into those cracks and past the inflammatory exudate, you will often find friends. There we go. So these are little cocci, bacteria, and they're often forming little chains. So there's intralenticular bacteria in this case. Another neat thing that we spotted in this eye, though, is the inflammation is kind of lens-centric, but it's a little bit more extensive. It kind of goes into the anterior vitreous or so. There's a little bit of involvement of peripheral retina. And along the edge where this sort of equatorial lens exploded, we have these little foci of sort of mineralized looking debris, which it could just be mineral, but then you see that looking up close that the neutrophils are kind of gathering around it, sort of very interested in what's going on there. And looking even closer, you can see how this like purpley stuff forms these club-shaped projections. Oftentimes in other tissues, they'll be eosinophilic inside the eye. For whatever reason, they tend to be basophilic. So this is Splendere Hopley phenomenon, which is probably basically just immune complex deposition onto the surface of whatever this is, some sort of debris. So we kind of have some interesting intraocular debris on this side near where the lens capsule rupture is in the equator. We have an additional lens capsule rupture anteriorly, and we have an endophthalmitis, sort of fibrinosuppurative associated with that. So there's some other stuff going on, the posterior synechia, glaucoma, things like that, but those were the features that were the most exciting. So I thought this case was kind of interesting. Let's see. These are some of the key diagnoses that we made. And so Coplow will describe something called septic implantation syndrome. So septic implantation syndrome is thought to proceed with an initial penetrating trauma, contaminated penetrating trauma, most typically a cat claw. Nature's cataract surgeons, they just need to work on their aseptic technique. This inoculates bacteria into the lens, and then oftentimes these cases, like the trauma will have happened even up to like years ago, and there'll be this period of intervening quiescence where not much goes on, and then the eye will just erupt with sort of a lens-centric endophthalmitis, which is presumably kind of that bacteria that was inside the lens. The lens is a relatively enclosed structure, but the bacteria sort of brood over time and then eventually sort of erupt and cause endophthalmitis. So kind of the key for septic implantation is that there's a sort of intervening period of downtime, if you will, while the bacteria kind of brews in the lens. It's somewhat different from just sort of a penetrating trauma that causes like a hot endophthalmitis right up top, and tends to be a little bit less lens-centric. So in this case, it could be either or. Maybe this dog had a contaminated penetrating trauma that wasn't necessarily noted in the history, and that explains sort of a more extensive endophthalmitis that extends a little bit more out past the lens, plus this sort of intraocular debris that we had. Or it could be a septic implantation syndrome that's just sort of a little bit more extensive inflammation that we often see. But either way, it just describes different sort of pathogeneses that we suspect, and the significance of the patient probably isn't, it's just an academic debate over what may have caused this. Overall, it is a contaminated penetrating trauma, and it demonstrates a couple of the things you want to look for in cases with a phakitis like that. So I thought it was pretty neat.
What's a breeding?
The breed, cattle dog mix. Yeah.
Genetically manipulated.
Yeah. They don't always describe the trauma. Presumably it's not always seen. Another thing that's interesting, actually, that I can talk about, which just reminded me before I discuss what I was about to discuss. The area where that equatorial lens capsule rupture had happened and most of the inflammation was actually lateral, which doesn't really help us. One thing to note is that if we do see a site of penetration in a globe, if it's more ventral, the thought is that it is more typically going to have come from the oral cavity, so like a stick penetrating trauma from the mouth of the dog, we've seen that, or something like that, versus more dorsal will tend to be like an external penetration, like a cat claw or something else. The other thing I was going to say is that they don't always describe trauma. Presumably it's not always witnessed. It's really rewarding when they do, though. We had a recent case of septic implantation where they came back to us and I was like, one owner was working with the veterinarian most closely, and then the other owner just happened to kind of like see the report and was all like, oh yeah, like we didn't describe that, like the cat did slash the dog in the face like a couple months ago, and you're all like, yep, there it is. So anyway, just kind of a cool case. And then we'll move on to this, which I think is sort of a pair to that one. Another dog. There's the gross. Yeah, there we go. This one is a 10-year-old spayed female beagle mix. They described crusted hemorrhagic discharge around the eye, a sealed iris prolapse, so a sealed corneal perforation with iris prolapse, that corneal vascularization, and yeah, so mostly just the corneal disease is what they described clinically, which is again presumably because they would have had a hard time seeing past this into the eye from the front. So you can actually see the advancing line of corneal vessels spreading into the corneal stroma. The cornea is pretty thick at this level. Our hemisection here is off center from the actual perforation itself, so I'll have to show you that histologically. You can see the iris sort of tracking towards the cornea, and then sort of between where the cornea may or may not end, it's hard to see grossly, There's this tan white and hemorrhagic exudates in the anterior chamber, or what's left in the anterior chamber. Plus a really upset looking lens, very opaque and an abnormal sort of collapse shape. So probably a hypermature cataract and maybe some other stuff. You can see a little bit of similar tan exudate in the posterior chamber lining parts of the uvea, plus or minus, we'll have to check histologically, a partial retinal detachment. So that's the gross. And here is histology. I'm going to choose this slightly deeper level that shows off the perforation site. I'm just going to go straight to this magnification rather than try the subgross. So we have the edge of the corneal perforation here. Just like they said clinically, you can make out the iris here. You can see its edges based on its stromal melanocytes, although it's fairly necrotic and inflamed. So you can only just see the outline of it and kind of track it as it prolapses out through this site of perforation. You can see the corneal epithelium sliding over the edges of that corneal perforation. And if we look closer here at the edge, the corneal epithelium has slid onto the surface of this otherwise bare flap of Descemet's membrane at the edge of this corneal perforation or rupture. So corneal perforation with iris prolapse and fibrin plug, just like they said. The interesting thing about this case, though, is that Descemet's membrane is multifocally ruptured and basically just gone. And in the anterior chamber, we have all of this inflammatory exudates, a really severe uveitis as well, and then similar exudate in the posterior chamber. And if you can't make out the lens, it's because it's barely there. We'll look closer in a hot second, but you can see these little fragments of pink. And looking closer at those fragments, these are bits of lens capsule, just exploded. And we have these inflammatory cells tunneling into the ends of these lens capsule fragments. So some bits of anterior and some bits of posterior here. And you may have already noticed these kind of suspicious purpley dots inside the lens capsule. I'm going to move over to the other side because I like that side better in this section. Here we are. We actually have a little bit more of the lens captured in this section on this side, some liquefied lens protein still in the capsular bag over here. And if we look at that lens capsule on this side again, up close, we again have these really suspicious purpley dots against that sea of homogeneous pink of that basement membrane type 4 type collagen. So here we are, a little closer. As we walk along, there are more of them. And more of them. And more of them. Gillian's whispering, go higher. So we shall. So these are fungal hyphae. And if you don't believe me, we will head to the GMS really quick. Same slide. This is a GMS, a silver stain, which can highlight fungal walls. Woo, and the camera is excited. All right. And here they are. That black is the silver, which is a nice positive result. And we have these fungal hyphae nicely highlighted in the lens capsule. Interestingly, I didn't see a whole bunch outside of the basement membranes. There were a few in Descemet's membrane as well. So this case, I think, is, I can find Descemet's.
Further, find a more longitudinal section.
The longitudinal section,
Yeah,
that's right.
I think people have difficulty identify them as hyphae just because what we're seeing here are cross sections. They're probably coming our way.
There's
There
maybe
you go.
one.
Yeah, that's a little better.
Maybe. There aren't a whole lot of them in here.
But it's just the way that I think they infiltrate and dissect Descemet's membrane that we tend to cut them on more like a cross section than a longitudinal section. So if you don't know what you're looking for, it becomes hard to identify them as such. Just for the pathologists out there.
Yeah. Yep, same sort of a deal. Yeah, this case was actually fairly light on the fungal hyphae, but they were definitely there. So this case, I think, demonstrates the tropism that fungal hyphae will often have for basement membranes inside the eye. Not exclusively, but if you're worried you have a pyogranulomatous endophthalmitis or so, it's a good idea to check out the lens capsule and Descemet's membrane, which are these good sources of carbohydrates for our fungal friends. Yeah, there's definitely some in Descemet's membrane. Maybe just believe me. For now, I'll stop looking. So maybe on the edge here. This is a case that was probably a contaminated penetrating trauma, this time with fungus that kind of took over the inside of the eye. No dice. The other possibility is that fungus can colonize Descemet's membrane and then sort of move to colonize the lens capsule. But given the large hole up front, it's much more likely in this case, we think that this was a contaminated penetrating trauma. But you can get deep keratitis and rupture of corneal abscesses that leads to maybe something that could look sort of similar. So here's the key diagnoses for that one. So a pair of contaminated penetrating traumas, one bacteria, one fungus for you. That's all I have. So I will trade seats.
All right. Here's my first case, the rare non-eye lesion that we present in rounds. That's not an eye, just so if you guys were wondering. This is from a horse. Is a sample that they describe as a periocular / skin mass with associated other smaller nodular lesions around both eyes, but this one was from the right eye of a 12-year-old male castrated Frisian horse. There's a lot that they describe here. They describe that as large, markedly thick and mineralized masses, and they took the largest one of them. So not much to describe grossly, rather than the fact that, so this is bisected, and you can see nodular areas everywhere. This was indeed markedly mineralized, and we placed it in decal solution for about a couple hours so that it could be sectioned. And this is something we don't see very often, but it's very cool. Let me go back to the slide. Good. Yeah. So you got both sections right there, right? And you can see right away that those nodular structures are pretty obvious. This was decalcified. So if it were not decalcified, you would have seen a lot of basophilic mineral associated with these areas, just preempting that. And in some of these nodules, they do have kind of a clear space in the middle, right? Besides, there's some necrosis, fibrosis, and some inflammatory cells around. Similar situation going on here. Let's jump right in. Go back one. Let me choose. I don't remember. I think they're both good, but there were a few that had better example. I think this one. All right. So we have these multifocal to coalescing nodules. This is a good example of one of these nodules where we have in the periphery lots of fibroblasts forming, a capsule-like structure. And here we have areas of mineralization. Again, it is decalcified, not completely. There's still some blueness to it. That's why the tissue looks a little bit cracked. So there are extensive areas of mineralized either collagen or osseous metaplasia. There are fibroblasts and some macrophages. The tissue will look a little bit different than normal just because of the effect of the decal on the cells. And there in the middle, we have some necrotic debris, some eosinophilic necrotic debris, probably neutrophils or eosinophils. And right there, there's something there, right? And I think we can go as far as something with this one, something suspicious. If you look around, you see that the same pattern replicates itself throughout these nodules, where you have these areas of mineralization with a central core of debris and something in there. Here are some areas with lots of eosinophils and red blood cells. You know, horse eosinophils are just pretty. These are actually red blood cells, but there are some eosinophils here throughout that stuff. And then here and there, you got a few that look a little bit more suspicious of being some type of organism. Right. I should have marked the better ones, but if you hang in there, we'll try to find. So there is a lot right away that it is suspicious of the diagnosis. Here's it's not showing really well because it's blown out a little bit, but these are cross sections of nematodes, that degenerated nematodes. So based on the history, based on the presentation of being a horse, and the fact that you have these mineralized granulomas surrounding nematodes, we have a very high suspicion that this is habronemia or habronemiosis. Oh, here's a better one, maybe. So they're degenerated, right? But it is fair to assume that these are degenerated nematodes. You got a tegument, you have some attempt on forming intracellular organs. Here's another one there. And that's what they kind of suspected too. Here's some eosinophils scattered throughout. So yeah, this is periocular habronemiasis or myiasis. Here's a better one. See, just say you can't find one and then they start popping up. Here's a better looking one where there's what looks like a cavity and some internal organs. So the reason we don't get this often is because they are clinically diagnosed just based on their classic clinical appearance, and they're treated or debulked, and they don't often get sent to the pathologist. This one was sent, and we are happy to receive them, just because we don't get to see them very often. But this is a beautiful classic case of periocular habronemia in a horse. Yep. Focal to diffuse granulomatous eosinophilic lymphoplasmacytic dermatitis with intralesional nematodes parasite consistent with habronemia. They're consistent with, we cannot confirm that's what they are just based on morphology, especially when the morphology is not readily accessible because it's all degenerated. We're just playing the odds here. Could be Drachia and Megastoma. There are other nematodes that can be present on that area. But that's good news rather than a tumor or something more nefarious. Like this one, speaking of something nefarious. First up, this is an eye. Let's start with that. This is the right eye of a, what are you? A cat, 4-month-old cat. There is lots of history. So we like history. Sometimes we complain when we do not get history. But sometimes we get a lot of history. See, I don't care about diarrhea 5 years ago, but here we go. The main description is a progressive iris pigmentation with cataract and secondary glaucoma. The cat did disappear for a while. And for a while, I mean about 2 to 3 years. I think that qualifies as a while. And he came back with marked ophthalmos and this pink lobulated mass that were extending through the ocular surfaces. And they described the corneal perforation. So can you imagine from the clinician's standpoint, you put this back inside the cat's head, right? You can identify the sclera there in the back, and that's about it, right? So if you're clinically looking at this cat, you only see this proliferation extending from what was perceived as, well, not just perceived, but accurately described as a corneal perforation. But it's kind of a corneal perforation plus, right? Because there's this white mass that's infiltrating and effacing the whole eye, extending through and causing that corneal perforation. And you can also see it here. We're kind of close maybe to the limbus, this mass, so extends into the orbit a little bit. Whenever we have something destroying the eye, I usually suggest we follow the pigment so we can try to follow the uveal tissue. So if we do that, here's what looks like choroid, right? And maybe ciliary body and the iris coming this way, maybe ciliary body and iris coming that way. So it's sort of, it's useful to try to get your bearings around what you're seeing, but not necessarily helpful in the diagnosis because this is a markedly distorted globe. So let's see what's up with this eye. I will try to get a low magnification. Impressively, our technicians found the optic nerve. We usually try to have them section the optic nerve for us. And in this case, I don't think we were very worried about it. We would definitely love to see it, but if they were not able to get, it would be totally understandable. But they're just awesome, and they did get the optic nerve. So as far as identifiable ocular structures, sclera, choroid, optic nerve, and then we move around. There's more sclera, choroid and sclera coming around. We're next to the equatorial portion of the globe, close to the limbus, and then it poof goes away. Similar situation on this side. And guys, remember, I was following that pigmented tissue on the periphery. So here is what was, the iris or ciliary body part of the uveal tissue. And here's the third eyelid, which, unaware of the situation around it, it's just like, yeah, I'll nictate around, and it's just there. But that is a useful anatomical landmark to show us that this is probably ventral, and this mass is extending into the orbit. So let's take a look and see if we can make anything out of this tumor. Okay, so remnants of what looks like cornea right here, and a little bit of Decimus membrane. Let me try to go the other way around. So we follow the same, relatively the same direction that we were looking at. So third eyelid, right? If we move back, we should have been kind of close or near the limbus. This is some orbital or extraocular muscles, or muscle bundle in that case. Here's sclera with some RPE cells. So we are at the choroid, moving along, then it disappears. Ciliary body, because these are the ciliary body plicate. And you can see that everything is effaced by this neoplastic population of cells. Oops. Let's try the other side of this eye. So bear with me. Here again, sclera, close to the limbus. Everything disappears. There's a little bit of cornea left, which is helpful. Here's the end of the Decimus membrane. So we're near the angle. And what's left of this cornea with the same neoplastic cells infiltrating and effacing everything. Right. So let's try to find a good area here. Maybe there. So once we start approaching this tumor, you realize that this is a neoplasm because it's a monomorphic population of cells. They're all cells of the cells, they all look similar, are cells of one type. There's lots of pleomorphism, lots of mitotic figures. So we know this, well, we didn't need mitotic figures to realize that this is relatively malignant tumor. But then when you look around, the cells, they have kind of oval to elongated nuclei, sometimes indented nucleus, maybe, resembling histiocytes here and there. There's a cute looking mitotic figure caught in a telophase. I thought that was you're never going to hear that word again after high school, but there it is. So lots of mitotic figures. There is pigment around. If you look around, there's melanin scattered, and you might convince yourself here and there that some of the pigment is inside neoplastic cells, like this guy, right? So you have a nucleus here, and there's this brownish amber pigment that looks like it's in the cytoplasm, kind of like this one. But the majority of the cells are not pigmented. You have the problem with the eye here is because there's a lot of native melanin from the uveal tissue, and neoplastic cells, they can't phagocytize free pigment when there's destruction and necrosis, like in this case. A good way to go around this, so we call the Gideon-Shaw's test. Go outside of the eye where you shouldn't have any pigment, and then look for pigment there. If the cells are pigmented here, they're probably, that's what they are, pigmented cells that suggest a melanocytic tumor rather than cells phagocytizing melanin. And then when you do that, you go outside the eye, they're not pigmented. There's a lot of hemorrhage, and the cells, again, they do have this kind of elongated, indented nuclei appearance to it. So very pleomorphic, very anaplastic. Look at the keramegalic cells, some binucleated cells. So at this point, we are dealing with either a very malignant tumor or a kind of a neglected tumor where kind of fits with the history of the cat disappearing for kind of 2 years, and basically they just let this tumor grow for all this time. Again, multinucleated cells, keramegalic cells, some signet ring sort of cells with a cytoplasm that's pressing the nucleus around. So we were not able to get a definitive diagnosis on this one. We just offered some potential differentials. So our main differentials were a feline diffuse iris melanoma, a very malignant one, extensive, of course, in this case, or something like a histiocytic sarcoma or an anaplastic lymphoma, anything in the round cell category. We offer a bunch of immunos. We haven't heard back from them yet. It's an old, well, it's not that, it's a 6-year-old cat. He's not that old. The margins are obviously compromised. So depending on the clinical presentation, it might be hard to do much about it. And that might be why they were not as inclined to go on with the immunohistochemical tests. So the axis is histiocytic sarcoma, feline diffuse iris melanoma. I think I added a post-traumatic sarcoma there just because of the distribution, and then a plastic lymphoma or post-traumatic lymphoma as an option. But at this point, it's really hard to tell. So regardless, prognosis really poor in this case, very malignant tumor, infiltrative with dirty margins, so very likely to recur. And depending if this is a histiocytic sarcoma or a lymphoma, for example, these are tumors that have propensity to become systemic. So there's a possibility that it will disseminate, not necessarily metastasize, but just disseminate, just because that's what they do. All right. Well, that's all we have for today. Thanks for coming. thanks for tuning in if you guys are online, and I'll see you guys in a couple weeks. Welcome.
Right.